Welcome back to the Deep Dive. Today we are pulling the curtain back on one of the most intense yet maybe least understood phases of the childbirth journey, the puerperium, often called the fourth trimester.
Right.
Everyone talks about pregnancy, those 9 months, right?
Yeah.
But the time after birth, that like 6-week recovery phase, it's arguably just as intensive, but often kind of glossed over.
It absolutely is. And, for anyone who needs to quickly get up to speed on the mechanics of recovery, what's normal, what's maybe a warning sign, well, this deep dive is kind of your cheat sheet. We're pulling directly from expert nursing and medical documentation here, trying to provide a precise, timeline-driven map of the physical and psychological changes that happen.
Right.
Our goal really is to move you beyond just the general knowledge and into specific, actionable insights.
So our mission today, uncover the hidden half of childbirth, moving beyond that myth that recovery is just, 6 weeks and you're good. We're going to look at the massive reorganization happening in the body and, well, the mind, too. So let's start with the basics. What defines this crucial time period?
Okay, so we're talking about the puerperium. By definition, this is the time of pretty profound physical and psychological adjustment. It starts immediately after the delivery of the placenta.
Right, yes.
And it lasts until the body is largely restored to a near pre-pregnant state. And that whole restoration process, it takes approximately 6 weeks. Though, as we'll get into, some aspects definitely take much longer.
6 weeks is the benchmark then. Okay, let's unpack this. We've really got to start with the most dramatic physiological changes. I mean, when the baby leaves, the body kicks off this rapid, complex rewind. What's the single biggest structural event defining this physical recovery?
That would have to be involution. That's the shrinking of the uterus.
Ah, involution.
Yeah. I mean, think about it. The uterus goes from roughly the size of a large watermelon down to the size of a pear. It's astonishingly fast, this process, though it does take about 6 full weeks to completely finish its descent and get back to its non-pregnant spot in the pelvis.
And what I find fascinating is that this isn't just like a slow, passive, deflating thing. The body actively wants this to happen quickly.
It does, yeah. And it uses existing hormonal pathways to help it along. What's critical here is that involution is significantly aided by 2 key things.
Okay.
One is the continued release of oxytocin. That causes uterine contractions, those actor pains people feel, which can be quite intense. And 2 is breastfeeding. Breastfeeding dramatically increases that oxytocin release. So those contractions essentially clamp down the uterine blood vessels, which prevents hemorrhage while also helping the organ shrink back down.
That makes perfect sense. So the body's using its own mechanics to handle blood loss and recovery at the same time. Okay, speaking of internal healing, we absolutely have to talk about lochia. This seems like a really critical indicator of how well that uterine wound site where the placenta was attached is repairing itself. Can you walk us through those 3 stages? They seem essential.
Yeah, lochia is basically the vaginal discharge that reflects the cleansing and healing of the inner uterine wall. And you're right. If this progression stalls, or worse, reverses, that's a major flag.
Okay.
It starts as lochia rubra. That's bright red discharge, lasting roughly days 1 through 3. It's very much like a heavy menstrual period initially.
So the first few days are really about active bleeding. Then what?
Then it transitions to lochia serosa. This is typically around days 3 through 10. The discharge gets thinner, it looks more pink or maybe brownish. It's mostly serum, old blood, and mucus at this point.
Okay, thinning out.
Right. And finally, it becomes lochia alba. This is a whitish or yellowish discharge, and it can sometimes last right up until that 6-week mark. It signifies the final stage of uterine healing is happening. The key insight here for the learner, for you listening, is that the color must progress forward. Red to pink to white. Any reversal back to red is definitely worrying.
That color progression really is like the body's internal stopwatch for uterine health, isn't it?
It is, yeah.
Now, let's talk about tissue healing outside the uterus, because this is where that 6-week myth really seems to break down. The timeline for the perineum, the area that might have sustained lacerations or an episiotomy, that's drastically longer than 6 weeks.
That's such a key nugget of knowledge right there, yes. While the immediate sharp discomfort subsides relatively quickly, the full, deep healing of the perineal area, we're talking muscles, skin, fascia, that can take up to 6 months.
6 months, wow.
It really is a marathon recovery, not a sprint.
Right.
We also look at the vaginal rugae, those internal folds that stretch out during delivery. They gradually regain tone, typically returning in about 3 to 4 weeks.
Okay.
But interestingly, this return can actually be slower if the mother is exclusively breastfeeding.
Why is that?
Well, the lower estrogen levels associated with exclusive breastfeeding keep the tissues a bit less elastic, so it just takes a little longer for that tone to come back.
Huh. It's just amazing how much the body is rearranging itself internally.
Yeah.
And speaking of internal shifts, let's quickly touch on vital signs and the blood itself. Because the body's chemistry is still adjusting dramatically. The source material mentioned an ongoing risk for clotting, using the term hypercoagulable.
Yes, exactly. The body remains hypercoagulable postpartum. This just means the blood is naturally thicker and clots more readily.
Okay.
It's actually nature's profound defense mechanism to prevent hemorrhage after birth, which is good.
Right, you need that.
But it does mean the increased risk for DVT, or deep vein thrombosis, continues for several weeks afterwards.
So movement and hydration are absolutely critical then for managing that risk.
Absolutely critical. And we monitor vital signs very closely, especially in the first 48 hours for some temporary anomalies.
Like what?
Well, many people experience temporary bradycardia. That's a lowered heart rate. And they might feel dizzy due to orthostatic hypotension when they stand up. That's because of massive fluid shifts happening in the body.
Makes sense.
Clinicians monitor closely, knowing these are usually just temporary adjustments to that huge drop in blood volume right after birth. And critically, you need to monitor any persistent or severe headaches.
Why headaches specifically?
Because they can signal serious conditions like a worsening of preeclampsia, which can actually pop up or get worse even after delivery.
Wow, okay, good to know. And wrapping up the physical side for now, what about the return of the menstrual cycle? When does that typically happen?
Well, that depends entirely on breastfeeding patterns.
Yeah.
If the mother is not breastfeeding, the cycle usually resumes in about 6 weeks, maybe a little longer.
Okay.
But with exclusive breastfeeding, the hormone prolactin suppresses ovulation. So the return is significantly delayed sometimes for many months. It acts as a form of natural birth control, though definitely not one to rely upon solely.
Right, not foolproof. Okay, here's where I think it gets really interesting. This isn't just a clinical process of physical repair. It's also this massive psychological shift, a true transformation of identity. And I imagine the physical exhaustion, that hypercoagulable state, the fluid shifts we talked about that must contribute directly to the mental fog, right?
Oh, that bridge is essential.
Yes.
The physical state absolutely dictates the mental bandwidth available. We look at psychosocial adaptations through concepts like maternal role attainment or MRA.
MRA.
Yeah, it describes the process of embracing this new identity, usually in stages. Anticipatory, formal, informal, and finally, personal. This whole journey is often just summarized as becoming a mother, or BAM.
It sounds like MRA is about moving from, okay, I have a baby, to, wow, I'm a mother.
Precisely. It's an identity overhaul. And it's deeply influenced by external factors, things like the mother's age, her own temperament, her previous experiences, maybe with other children, or even her own upbringing, and critically, the quality of her support system.
That makes sense.
But in those immediate days right after birth, we often see predictable emotional patterns. These are known as Rubens phases.
Okay, Rubens phases. Let's define these first few days. What characterizes the taking in phase?
So this is usually the first 1 to 2 days. The mother is typically quite passive, maybe dependent. She's focused on her own basic needs, rest, nourishment, maybe wanting to talk about the labor story, reliving it.
Processing it.
Exactly. Processing the trauma or maybe the elation. She might be very quiet or extremely talkative, but she's not really taking full responsibility for the baby's care just yet. She's kind of in survival mode.
And then there's a switch that flips
Yeah.
to taking hold.
Usually, yeah.
Yeah.
Around days 2 or 3, the taking hold phase begins. This is a really crucial turning point. The mother starts demanding responsibility for infant care. She wants to learn, she wants to bathe the baby, change the diapers.
Getting active.
Yes, getting active. But because this is a brand new high-stakes skill, she may feel incredibly anxious, unsure of herself, maybe very sensitive to criticism or feeling judged.
Okay, so if anxiety and weepiness are key markers here, how does a healthcare provider or even a family member tell the difference between that sort of normal new mom anxiety inherent in taking hold and maybe the start of something more clinical, like postpartum depression?
That's the million-dollar question, and it's a critical distinction. We fully expect the postpartum blues. That's considered normal.
Right.
These involve that initial fatigue, maybe excessive weepiness, mood swings, pronounced irritability, crying over a dropped pacifier, that kind of thing.
Totally.
These usually peak and then fade within a week or 2. What signals a need for referral for more help is profound sadness or excessive anxiety that really interferes with her ability to function, maybe detachment from the baby or a sustained refusal to care for the baby.
Okay.
If those feelings persist past 2 weeks, or if they seem to be getting worse instead of better, that signals potential clinical depression or even psychosis, and that requires immediate intervention.
Absolutely crucial distinction. And speaking of attachment and connection, the source material laid out some observable bonding behaviors that clinicians actually look for. What are those?
Yeah, we look for a kind of progressive shift in interaction. It often starts with just fingertip touch on the baby.
Gentle, tentative.
Exactly.
Yeah.
Then moving to palmar contact, using the whole hand, and then full holding and enfolding the baby. We also look for the mother achieving the en face position.
In face.
Yeah, where she holds the baby so they're facing each other, really facilitating that intense eye contact. And this is often accompanied by that high-pitched, sort of excited talking that parents do.
That parentese.
Right. All these are cues that the critical emotional bonding is successfully progressing.
That's fascinating to watch for. Okay, now let's shift focus slightly to the nursing watch list. This is the crucial information for ensuring safety during this really intensive recovery period. Let's start with that all-important measure of uterine health, checking the fundus.
Right, the fundus, that's the top edge of the uterus. It absolutely must be firm, midline, and descending appropriately. We actually measure its location in relation to the umbilicus, the belly button.
How so?
Initially, right after birth, it might be about 1 centimeter above the umbilicus, but it should drop by about 1 finger breadth or 1 centimeter every 24 hours.
Okay, so there's a predictable path downwards. What's the major red flag then? What indicates immediate danger when checking the fundus?
A boggy or a displaced uterus. Boggy means it feels mushy or flaccid, kind of like a wet sponge instead of a firm, hard ball like a grapefruit.
And that's bad because...
That's a massive bleeding risk. It means the uterus isn't contracting effectively to clamp down on those blood vessels at the placental site.
Got it. And displaced.
Displaced usually means it's shifted off to one side, often indicating a full bladder is pushing it out of position. And that also prevents it from contracting properly.
And the immediate, like the absolute first-line nursing response to feeling that spongy, boggy uterus.
The core primary response is immediate fundal massage. The nurse has to physically massage the fundus, quite firmly sometimes, until it becomes firm. And if a displaced uterus is suspected because it's off to the side, the mother must be encouraged to empty her bladder immediately.
Right.
That quick action is genuinely life-saving.
Wow. Okay, we discussed Loki earlier, that discharge. But when does that normal progression cross the line into being a serious warning sign?
Okay, so abnormal lochia signals include passing large clots. Generally, anything bigger than, say, a golf ball needs investigation.
Okay.
Or heavy bleeding. Practically, that's defined as saturating a peripad in 15 minutes or less. That's too much. A foul smell is also a strong indicator of potential infection.
Makes sense.
But the really critical warning sign we mentioned is the regression of lochia. If it had progressed to serosa, pinkish, or alba, whitish, and then it goes back to bright red rubra, that often signals subinvolution.
Subinvolution, meaning?
Meaning the uterus has stopped healing and shrinking properly. Something's interrupted the process, possibly retained placental fragments or infection, and needs urgent attention.
Got it. Regression is the big key word there.
Okay.
Let's move down to the perineum. We know full healing takes months, potentially up to 6 months, but what are the immediate red flags for infection or maybe a hematoma down there?
Right. For immediate assessment, we often use the REEDA acronym. That stands for redness, edema, which is swelling, ecchymosis, bruising, discharge, like pus, and approximation, how well the stitches, if any, are holding together. Excessive redness, swelling, foul discharge, or stitches pulling apart are signs of infection. A hematoma is different. That's a severe collection of blood under the skin. It typically presents as significant sudden swelling, maybe deep bruising, and crucially severe, unrelenting pain that isn't relieved by standard pain medication.
That sounds awful. And what are the classic comfort interventions nurses use right away?
Yeah, immediate nursing care focuses on reducing that inflammation and pain. So standard practice is applying ice packs or cold packs intermittently for the first 24 hours.
Ice first.
Ice first, definitely. After that initial inflammation starts to subside, then we often encourage warmth and cleansing through sitz bath, just soaking the area in warm water. And using soothing agents like Tux pads, which contain witch hazel, can really help reduce swelling and irritation too.
Ice, then warmth, and soothing pads. Makes sense. Now, I found a really fascinating little nuance in the source material about assessing for blood clots, DVTs. It specifically highlighted that the traditional textbook maneuver, the Holman sign, is explicitly not used in modern practice anymore. Why the caution there?
Yeah, that's one of those key shifts in clinical practice that, learners really need to be aware of. Clinicians are absolutely still assessing for signs of brumbophlebitis. They're looking carefully for calf pain, swelling, heat, or redness.
Okay, so the assessment is still happening.
Definitely. However, the traditional use of the Homan sign assessment itself, which involves sharply dorsiflexing the foot, bending it upwards, that's discouraged now.
Why?
Well, the thinking is that performing this specific maneuver carries a small but still unacceptable risk of potentially mechanically dislodging a clot if one is actually already present there in the leg vein.
Ah, okay, so you could potentially make things worse.
Exactly. The risk, however small, isn't worth the limited diagnostic benefit of that particular sign.
So we're still vigilant about the symptoms of clotting, but we prioritize non-invasive monitoring and, I guess most importantly, prevention.
Absolutely. Prevention is paramount here. That means encouraging fluids and especially early aggressive ambulation. Getting the person up and moving around is probably the single best intervention.
Get walking.
Yep. And that's often supplemented by mechanical devices like sequential compression devices, those SCDs that squeeze the legs, especially after a C-section where mobility might be limited initially. So if we sort of synthesize our deep dive here, the perium, this fourth trimester, it's really a time defined by an incredibly predictable, structured sequence of physical milestones. You've got uterine involution, that structured progression of lochia, rapid circulatory stabilization.
Right, these very concrete physical markers. And they're running concurrently, side by side with those massive shifts in identity, guided by predictable psychological phases, like Rubin's taking in and taking hold that you described. It's really an integrated physical and emotional experience, isn't it?
Completely integrated.
Huh.
And understanding those expected changes and maybe more importantly, knowing those key warning signs like a boggy fundus or that critical regression of lochia back to Reddit really empowers you, the learner, with knowledge that goes far beyond just that generalized 6-week recovery expectation.
It definitely reframes the idea of recovery for me. Because while the body's physical repair might meet most clinical expectations in about 6 weeks, that transition to maternal role attainment involves those deeper formal, informal, and personal stages of identity transformation. It makes you wonder, how might recognizing that the complete psychological transformation of becoming a parent is influenced by factors like external support, her age, her own temperament? How might recognizing that change how society defines full recovery from childbirth? That's definitely something profound to mull over the next time you just hear the term 6 weeks.